Welcome to today's Expedition Seminar of the Institute of Experiential AI at Northeastern University. Today I have the pleasure to introduce Annika Marie Schoene, a research scientist at the Institute. She did her PhD at the University of Hull in the United Kingdom, and then a postdoctoral fellow at the University of Manchester in the National Center for Text Mining, where she worked at NLP for mental health. Today she will talk about responsible AI for suicide prevention, as she is a research scientist in the responsible AI team of our institute. Thank you, Annika. The floor is yours.
Awesome. Thank you. Hi, everyone. Thank you so much for coming. And before we get started, I'd like to spend a few moments to raise some awareness around suicide and put into context how big the problem actually is. So let me talk you through some numbers. Here you can see some suicide trends for some selected countries. This is a graphic from the World in Our Data starting in 1999. And just so you know, we selected some of these countries because they have similar or higher suicide rates than the United States. And you can see clearly that not only are the United States consistently on the rise for it, they are actually outperforming a lot of other Western countries on it. If you're interested, you can actually go on the website yourself as well and play around and look at some of these statistics and also select some countries. Of course, not every country actually reports on their suicide rates, so you will see not every country on the world on there. And also for some countries, the reporting might actually stop halfway through the decade because there may have been a change in policy of how reporting takes place. Suicide is often a tough and complicated topic to talk about, especially because it's still stigmatized and considered a taboo in many countries, cultures, and communities. So when we talk about how many people are impacted, we often get statements like this. Suicide is the fourth leading cause of death for people aged 15 to 29 worldwide. Or something like this, every year over 700,000 people die by suicide worldwide. But I don't think it often gives context to what it actually means. So I pulled some more numbers from the CDC that I think illustrate the scale of the issue in the US alone. The numbers you see in the graphic on the right are the annual numbers. So every 11 minutes, someone dies by suicide. And we know that for every suicide, there are many, many more people who consider it, make a plan, or attempt it. Of course, some populations experience more negative social conditions and have a higher rate of suicide compared to the general US populations. Examples of such groups include veterans, people who live in rural areas, sexual and gender minorities, middle-aged adults, people of color, and tribal populations. However, it's really, really important to keep in mind that it's incredibly hard to determine an accurate number of deaths, not just in the US, but more so worldwide. And there are a couple of reasons for this. One reason is that, like I said, suicide is a taboo and stigmatized, but in some countries, it's actually outright illegal. And in other cases, where someone uses a method such as overdose, it is often really hard to determine if this was intentional or not. Some people, companies, governments, and not-for-profit organizations are acutely aware of the problem and have developed AI-based solutions in recent years for a variety of suicide prevention technologies. Different tasks and benchmarks have been directly translated into product, for example, on different social media platforms, but also in clinical settings. For example, for language. Here, linguistic cues and patterns or expressions of emotions are used to detect if someone is at risk or has the intent to die by suicide. Of course, more recently, language models have also taken off. Similarly, for vision tasks, examples include detecting if a person is on the wrong side of a fence in a video, or if the images a person posts provide insight into the current mental health status. And finally, there's also some recommender systems. And a good example here is the use of health information by typically insurance companies or clinics to make decisions about claims or treatments. From my experience, unless you are in this space, you typically don't realize what companies are using AI or machine learning-based technology to detect suicidal risk, intent, or attempts. The use cases I'm talking through here are not exhaustive. This is not a full list. It's just to give you a little bit of an idea. Of course, you have social media companies like Instagram and Meta who use this type of technology to flag content for review. So for example, if there is an image or a video put online by someone self-harming, they would obviously like to stop the spread of that image. And then you have a whole host of government and clinical organizations that try to identify individuals who are at higher risk using their health information. A good example here is a program by the US Department of Veterans Affairs who use something called ReachVet. And then, of course, you know, especially over the last few years, there have been a host of new startups that actively collaborate with hospitals, medical facilities, and sometimes insurance providers to give them the opportunity to use artificial intelligence in some shape or form. For example, Talkspace uses artificial intelligence for talk therapy or risk assessments. Now, where did this all start really? So the first study that most people were able to find was conducted by Huang et al. In 2007. And they used a dictionary of keywords and phrases to mine blog posts on MySpace. The following year, seminal work by Pestin et al. Was published at ACL, and their key hypothesis really was that a machine learning algorithm would be as good as a mental health professional, if not better, in distinguishing a genuine from a forged suicide note. Of course, from this kind of a flurry of activities started, including the first shared task. However, there was really one key challenge for most researchers in that space, which was accessibility and scalability of data. So up until this point, the majority of work from the medical community was on genuine suicide notes. But of course, to a lot of people outside of the medical community, that wasn't accessible. So what ended up happening is that most CS researchers became, really interested in social media platforms such as Twitter. And that's where we observed the first big shift away from, just using genuine suicide notes that have been verified or electronic health records to publicly available data. And here the key argument really was that most people express their thoughts and feelings online, and therefore they would also express if they're suicidal or not. And of course, whilst this was going on, the medical community continued working on interviews, transcripts, but for today and for the majority of this presentation, I will focus on the public space. And then from a methods perspective, in 2016, neural networks started really taking off. So up until then, a lot of work used traditional machine learning approaches, using feature engineering or emotion annotations, linguistic patterns, et cetera, in support vector machines or decision trees. But as neural networks became more and more popular, they shifted away from that, and especially for suicide-related tasks. Of course, I'm only referencing a small subset of studies here. There is a whole host of more stuff out there. So how is it really going? In 2019, most neural network-based approaches are replaced with some shape or form of a language model, specifically BERT. The reasoning behind this really is that researchers for the first time were able to incorporate context in a more meaningful way. So a lot of neural network-based approaches that relied on recurrent neural networks, convolutional neural networks just dropped off. And with that, really the use often of linguistic features. In 2020, we had the first dedicated review that highlighted how artificial intelligence and machine learning, specifically for natural language processing, is used in suicide ideation or risk detection. And often the popular tasks referenced in here assumed a binary classification scale of suicide. And by that, I mean, really, you're either we stream your data and you're either suicidal or you're not. And in terms of how data was collected, it was often done on subreddits, for example, publicly available on Reddits called, r/suicide watch, or people used specific keywords. In 2021, a first language model for detection of mental health disorders is released, and it is also tested on suicide-related tasks, including ideation detection and risk classification. And I think everybody probably has this at the forefront of their mind. ChatGPT is released in 2022. And now we see many more startups, and some of them I showed earlier, using such technologies in their product or in their company. However, in 2023, we see the first emerging research that ChatGPT actually rates the risk of suicide attempts lower than mental health professionals in all types of experimental settings. It also rated mental resilience a lot lower than, in most other conditions as rated by mental health professionals. And these results really imply that those who rely on it, either fully for decision-making or even just as an assistant, may receive an inaccurate assessment that underestimates the actual suicide risk. And obviously, that is only one of the most recent challenges in using AI for suicide prevention. Of course, with the advances of artificial intelligence, understandably, everyone is really excited what especially predictive analytics could do to reduce or prevent suicide. However, there are some important challenges that make it an incredibly complex and dynamic phenomena to capture. This is not an exclusive list of all the challenges, and I will touch on some of these points throughout the following slides too. But first of all, risk assessments are rarely binary and really require a comprehensive set of clinical tools to understand if someone is experiencing suicidal ideation or is making an active plan. And they definitely require more than a single post, for example, from social media. And even though numbers are on the rise, when we compare it to the general US population, suicide is a relatively rare event. And for rare conditions that engender high false positive prediction rates, several considerations needs to be taken into account. For example, the seriousness of the condition, the adverse consequences of being misclassified, and the availability of second-stage methods to actually confirm a diagnosis. Now, some of this is also problematic when it comes from a lack of interdisciplinary research. There seems to be a gap right now between those who have the technical skills to develop new algorithms, advanced algorithms for such tasks, and those who have the medical skills to actually ground research in clinical studies. And so we find that most papers from either side either are very technically novel and not clinically grounded, or not so technically novel, but very clinically grounded. Another issue is, specifically when it comes to social media, there is no ground truth. So most of the time when researchers collect that kind of data, they either use keywords and automatically assign a label to a single post. But even when they use annotators with expert knowledge on the subject, they can only assess a post and provide a label based on their subjective opinion. So we actually never really know if that person, actually was expressing suicidal intent or ideation. And of course, that is even more concerning when we think about the fact that even medical professionals who go through years of rigorous training still struggle to accurately predict if someone is at an elevated risk. And then finally, and I've alluded to this a couple of times, is that the data sets that are being collected typically rely on something called suicide-related keyword dictionaries that have been validated. But oftentimes what we actually find is that those data sets or corpora don't actually include tweets or posts that reference suicide in the way that the task is set up. So we have asked the question, what are we actually collecting when using keyword search? We conducted a study where we used the same method as multiple other papers to collect new data that is meant to be indicative for suicidality. You can see some example keywords from a popular dictionary for identifying suicide-related language on social media up here on the left. Of course, each of these tweets here talks in some shape or form about suicide, but do they really convey intent or ideation? In fact, so much so that they can tell us if someone is at risk. So instead of categorizing each tweet into a binary category like labels, suicidal versus non-suicidal, We looked at both the content and conveyed emotions of a subset of tweets. We asked 3 mental health professionals to rate each tweet for one of the following content categories. We used an existing coding framework from psychology to categorize each of these tweets. And what we actually found is that the vast majority of tweets in our subset are actually not relevant at all to detecting suicidal intent, ideation, or risk. Now, how is this useful? For example, most Western countries have policies or guidelines, or both, for the media, including the online media, on how to report and broadcast on suicide. And these recommendations list content characteristics that have been deemed either harmful or protective. For example, discouraging extensive reporting on celebrity deaths in the news. This could be a meaningful way to help with content flagging and enforcing national policies. Now, let me show you the actual labels for each of these tweets. And you can see, for the tweet that has been labeled expressing own suicidal ideation, we have a laughing emoji, whereas the humorous use one actually contains an emoji smiling with a little tear. This made us really curious about the emotions and patterns in this type of content, which has often, as I already said, been used as a feature to increase the accuracy in predicting suicide risk. In this work, we are following up on one of the findings from this previous papers, where we had already annotated each tweet for emotions as they relate to suicide content. And more specifically, we had annotated each tweet for Ekman's 6 basic emotions. Of course, this is somewhat limited in itself, as a tweet could also contain more than one emotion or not really neatly fit into one of those categories. And similar to the idea of not knowing ground truth or suicide risk, we don't really know what the intended emotion is. We can only assume or project based on the human annotations that we have. But here we were really wondering if a language model would be able to replicate those results. One of the reasons for this is that it's now really cheap and quick to basically make a prediction for emotion and sentiment and cut out expensive human annotation. And that's because, model zoos, such as Hugging Face, provide language models that can do that with you with a few lines of code. One very obvious downside is, of course, there is no quality check to ensure that the emotion or sentiment label is actually a good approximation. In our study, we used the emotion labels from the paper I previously introduced called Twisco, and we compared it to 3 different language models. On the left-hand side, you can see what kind of emotion levels are present in each language model compared to the human annotations. Of course, for Roberta and Distil-Bird, the match was not complete. However, the most recent model, Distil-Roberta, matched perfectly with our original annotations. We then proceeded to generate a set of confusion matrices for each language model to show how accurate each is compared to the human annotations. On the right-hand side, you can see one of those confusion matrices for the human annotations and Distil-Roberta. And this is specifically for the category expressing your own suicidality. Our results showed that there is really no overarching pattern, and the highest agreement between humans and the language model in this case was for the emotion category anger. And that pattern repeated over all other suicide-related categories and language models. This led us really to consider that language models for emotion prediction may not be actually capable to finding finer distinctions in granular suicide-related content. Our findings also led us to question how useful and credible such techniques are when you want to use emotion features in suicide detection tasks, especially given that this is a really high risk scenario and a high false positive rate could cause real harm. I now want to switch gears a little bit into the clinical world and talk briefly about what factors drive suicide that are not based on emotional cues and linguistic features, which is, like I said, mostly in suicide and social media research. This is a post I have found a couple of months ago, and I feel it accurately points towards a broader problem that is currently not discussed often enough. I'm sure many of you here have heard of social determinants of health and how they influence not just mental health outcomes, but other diseases. However, if you haven't heard of them, social determinants of health can be summarized as the social, economic, political, and physical factors that contribute to adverse health outcomes, including suicide. Therefore, we wanted to understand how artificial intelligence has been used to extract what the causes or contributing factors are as they lead to an increased risk of suicide. We conducted a review of over 90 scientific publications at the intersection of AI and SDOH, with a special focus also on NLP methods. And first, what we found is that the vast majority of studies actually use a very limited set of SDOH information. And the majority of studies focus, for example, on abuse and trauma in adulthood, socioeconomic issues, what kind of occupation you hold, or if you've experienced any issues in your relationships. But very few looked actually at equally important factors such as housing insecurity, like legal issues that may be putting a lot of pressure and burden on you, food insecurity, and the impact of discrimination. Of course, most of these papers focus on more than one SDOH at a time, but still the vast majority focused on these few core factors. We were already interested in not just what are the factors, but who is impacted or researched in those studies. So we looked at social identity and demographic factors, and we found that minority groups that are traditionally disadvantaged in the healthcare system are often not even represented. So typically, papers focused on factors such as sex, race or ethnicity, and age. However, very rarely they looked at the marital status of the person, the sexual orientation, or disability. And of course, there are different reasons why there's so little research available. But what it ultimately means is that the tools and algorithms we're currently developing work very well for a selected group of people, leading to a risk of misclassification in any other populations. So this review really shows us quite clearly that, there are many more factors contributing to suicide outside of linguistic cues, emotions, or even just the previously diagnosed mental health conditions. But there is, so much more research really needed to get a holistic understanding, especially for minority groups that are more impacted by health disparities. As part of this review, we also looked at, for example, what the most common data sources are. Here we had the vast majority of work looking at electronic health records, as well as interviews and surveys. We also looked at the methodologies used, for example, feature-based machine learning or neural networks. This really alludes to one of the challenges that I've pointed out earlier in terms of technical novelty. Because even if you see the term neural networks up on here, that actually doesn't mean any kind of more recently developed language models or transformer-based models. It refers mainly to multi-layer perceptrons or sometimes recurrent neural networks. One key challenge in extracting SDOH is that is often conveyed in free text and not available in neat tabular format. Actually, a recent review found that only 2% of electronic health records record SDOH factors in pre-populated fields. And of course, clinical staff write down vital information in free text, but due to time constraints and intense workloads, they often can get overlooked, especially if information was written down 6 months ago. To solve this issue, we have developed a proof of concept study extracting nine distinct SDOH categories. And here we asked annotators to annotate free text for SDOH. And next we ran standard NER methods to extract information from previously unseen free text. This graphic really just shows an abstract example of a self-reported mental health diagnosis to illustrate the process. This is actually not a real electronic health record excerpt. And you can see on here factors such as the economic status. You can see the treatment type someone may have received, alongside of symptoms, which are more typical pieces of information in the electronic health records, alongside of, like the social issues that a person might be experiencing. Of course, this is still work in progress, but it may actually offer a long-term solution to help clinical staff quickly view SDOH information from previous consult if we could automatically extract that information. At this point, it's quite clear that there are some opportunities, but also some risks in using AI for suicide prevention. And major news outlets are increasingly reporting on the negative or positive impact of AI in suicide prevention and mental health at large, really. So, for example, only last year, we had the first person die by suicide after an interaction with a chatbot. At the same time, the algorithms and tools that are being developed and deployed are actually not necessarily have to be hosted in your country. So for example, in the case of a Chinese suicide that was prevented, the actual tool and server and methodology was developed in the Netherlands. And of course, people are getting concerned how harmful content spreads online, especially when there's emerging and existing evidence that social media platforms keep pushing certain types of content to vulnerable groups. However, at this point in time, there is very few guidance or regulatory work as to how these kinds of technologies can actually be used. So my colleague Laura here at the Institute and I have been making an effort in that direction. And just as a little disclaimer, I'm not a trained philosopher or ethicist, so I will try my very best to represent this work. But we started out with really asking ourselves, why is this ethically relevant and why should we do this? And some obvious kind of points come into mind. There is no regulation, mandatory oversight, or governance, meaning anybody in a startup, a private citizen, or even a big corporation can just go and develop and deploy these tools. Whilst also not having really any mandatory healthcare or ethics training. So even if I haven't gone through medical school, for example, I can sit here and develop such a tool or product. And finally, given the potential high risk of misclassification, there seems to be an awfully low benefit right now. Overall, these concerns led us to distinct ethical issues where we took inspiration from the box by Chansha to flesh these concerns out. So what do such guidelines actually look like? I'm just going to give an overview here, and this is by no means comprehensive, and it is inspired by the 3 basic principles from bioethics too. So there are these 3 principles, for example, of autonomy. What should we really look at here? We should inform users of the tools and how they function. There needs to be a pathway for user feedback and let people understand why they were targeted. We should also provide a clear path for help after targeting. It is not just enough to identify a person if you choose to do so or develop a product like this, but also offer help. And then there's the harm versus benefit framework. And you want to really ensure that everything is documented efficiently. That's really, really crucial. Suicidal risk or ideation predictors should solely be determined by mental health professionals and based on empirical evidence. Collected data should never be sold or in any other way transferred to third parties, nor should it be stored longer than absolutely necessary. And then, of course, there is, the legal system and justice where ongoing bias audits should be mandatory and ensure that, a user can opt out or mark themselves as non-suicidal after being targeted. And then the final bullet point really speaks to the type of technology that's currently being developed, where a lot of the tools, specifically language models right now, are not based on individual languages. Oftentimes, they are automatic translations from English, meaning that they often miss a lot of concepts and contexts that are culturally relevant. Like I said, these are just 3 short bullet points for each of these concepts. There is a lot more depth to this, of course, and you're either happy to read our little paper about it or speak to Laura directly. Now, what are the key takeaways here? At this point in time, with the technology we have available to us, we should not be predicting anyone's suicide using artificial intelligence, really. Of course, AI can be a useful tool to aid in understanding of causes or factors for ideation or intent, but healthcare professionals, trained healthcare professionals, are essential in grounding any kind of outputs and decisions that we make based on it in a psychological theory and to the real world, so that the tools that are being developed are actually useful and applicable for the context they're being used in. And finally, it's really important to remember that suicide is almost universally stigmatized. I'm not just talking about the countries where it's illegal, but actually just as a taboo in society here in the US too. And of course, we want to prevent artificial intelligence from increasing any kind of stigma or harm. And so there needs to be a really careful consideration around how we deploy such technologies. And then finally, if any of this is interesting to you, we'd love for you to get involved. We are holding a first workshop as a series of workshops on responsible AI for mental health. The first one is going to be in London in the UK. However, we are trying to make it hybrid, and we have more details available on our website soon. And that's also where you can subscribe to our mailing list. And then finally, of course, I'm not doing any of this work alone. By all means, there are some great people involved in shaping and all of this research. And yeah, thank you so much. I'm ready to take questions now.
Thank you, Annika. A great presentation. So we have a few questions. Let me read it for you. So the first one is, how do you ensure the AI models are transparent and accountable in sensitive contexts like mental health?
So right now, there are few explainability and transparency techniques. However, I have to be really honest, none of them have been specifically developed for the mental health application or task, or in clinical settings, for example. I think I've alluded to this a little bit. Right now, there is no governments or regulation even on how to develop any of these technologies, and that includes explainability and transparency.
So the second question, after acknowledge your work, is, have you found any relationship between expressions of chronic and managed physical pain and suicide?
So this is an interesting one, not in my work specifically. However, we already know that people who have chronic conditions, specifically those that cause pain, are at an elevated risk of, for example, having a mental health condition. And I think this is where it's really interesting when we look at the factors that are currently being investigated in electronic health records, such as disability. Nobody looks into it right now. So as much as we'd love to have more information on this, there are so many pockets of research that are still underdeveloped that it would be great if we could use, any kind of AI or machine learning based tool to automatically extract this information and help us draw these conclusions. But in my personal work so far, no.
Let me continue with a question related to that one. It's curious, Sabrina Siddle asked, curious if there is a data around the origination of mental health issues and to what extent it can be attributed to social media or a natural pathology.
Yeah, so obviously we know that this is what I kind of tried to say earlier, like suicide and mental health is an ever-changing dynamic and really complex phenomena. So you can't really just single out a single factor like social media or any kind of natural causes or genetic causes. There is, for example, genetic testing going on to see if you are at elevated suicide risk. However, the truth right now seems to be that there are so many different variables that all of them could negatively or positively act as risk or protective factors. So whilst social media can have a really adverse impact on a person's mental health, there's also studies that show people who use social media for community building and exchange experiences, it can be really useful. So it seems to be this perfect mix almost, unfortunately, of various factors that increase and elevate your risk, not just for a mental health condition, but also for being at higher risk of suicide.
So the next question is, how should healthcare companies ensure AI systems are integrating with the existing electronic health records to enhance the accuracy and timeliness of suicide risk assessment while ensuring compliance with data protection regulations?
So that is a very complicated question that also requires a very complicated answer. First and foremost, I would say you probably need a team of interdisciplinary scientists and ethicists, philosophers, computer scientists, clinical scientists that work together to find unique solutions, because one thing that holds very true is not every electronic health record or setup is the same. Not everybody uses the same uniform language models, and there are different challenges depending on which type of technology you use. So ideally, you work with an auditor, independent provider that has the accreditation, expertise, knowledge, and experience to actually work in those kind of settings.
So another question from Greg Howard. With the current tools not being appropriate for suicide prediction, are there other mental health conditions that you consider appropriate to predict with these tools?
I think I would steer away from prediction altogether. That's a personal opinion, just because of how the technology works and how we know what kind of people are currently represented in the data sets that we have. I think artificial intelligence can be incredibly useful, even in an assistive way, but I wouldn't single out a single mental health condition that we are good to go to deploy artificial intelligence on. I think at the end of the day, it always boils down to the fact that we need interdisciplinary teams to make sure that the technology that's being developed is applicable to the context. And so predictive analytics, as exciting as it is, the high rate of false positives is really, really concerning to me, and the harms that it could cause, really.
Yeah, to complement that, for example, these kind of techniques that have been useful also for learning issues, like people with dyslexia, ADHD, and other of these types of things that are not mental health, but also affect people.
Yeah.
So the next question is, you mentioned some various types of data sets that are being used for mental health NLP analysis. What are some of the fallbacks of using those data sets? And what do you think would be a more ideal data set to use to build mental health specific AI tools and LLMs?
So that's a really good question, actually, because right now we are struggling even at the baseline, which means we have no benchmarking tools, right? So if you develop any kind of language model, tool, or technology, you have no means of benchmarking it, especially when it comes to social media data. So for example, the vast majority of data sets that have been developed and collected and used for experiments, language models, and trying to build a benchmark, they are not reproducible. And there's one simple reason for this, really, where social media users obviously have the right to withdraw their information. So let's just say I collect a data set on Reddit or Twitter, and according to data sharing laws, I can only share with Ricardo the IDs. And then Ricardo goes and wants to replicate my research. So he takes the IDs, but maybe 10, 15, 20% of those users have actually stopped, pulled their content. So we actually have no complete data set anymore. So that's a very unique challenge to the social media space. And actually, maybe the creation of synthetic data sets through generative AI could be a solution for that. I know some people who work on this kind of stuff. But then in reality, when we look at it, when we want to have clinically applicable and clinically grounded data sets, tools, and technologies, we should be working with clinical data, right? However, that is not as easily accessible to the vast majority of people in research, because for very good reasons, HIPAA compliance, all sorts of rules, laws, and regulations, those can't be readily accessed. So in an ideal case scenario, we'd be working with real data to develop clinically grounded tools, but that wouldn't be the vast majority of researchers right now.
Yeah, we have another anonymous question here. After thanking your work, the question is, in your research, is there any correlation between childhood trauma and suicidal rates? Although I will also specify that we need more than correlation, we need causality.
Yeah, so there are when it comes to suicide, there are risk and protective factors, and within the set of risk factors that exist, that also partially match SDOH, for example, things such as childhood trauma, which include any kind of trauma, i.e. bullying, sexual or physical abuse, emotional abuse, seeing a loved one pass away. So for example, if a parent, dies either of natural causes, also by suicide, those elevate your risk factors. Now, that doesn't mean, therefore, you will 100% also struggle with suicidal ideation, but there is some causation that you're at higher risk. The fact is, however, in the review, which hopefully should be coming out soon, you'll see that the vast majority of tools and technologies, data sets, they don't even screen for that. So people look a lot at like adult trauma experience, for example, in the military context, that is typically for veterans, you know, that have been deployed in war zones. But rarely do we know or have comprehensive understanding of a person's childhood trauma experience. And so if the data exists as it stands right now, it is not actually used in a lot of machine learning or AI-based applications to look at predicting risk, basically, or intent or ideation.
So we have yet another question from an anonymous attendee. So is there any research that assesses the impact of preventive AI-driven apps? So basically interventions. Put as an example, apps that prompt people to self-assess their state of mental health and then refers or automatically connects people who self-assess at high risk with support resources.
Yes, so there is some qualitative research on this out there. The research that I am most familiar with is actually evaluating the underlying technologies such as ChatGPT for their ability to do assessments. However, at the intervention piece for specific applications, I'm sure there is some qualitative work out there. However, I haven't worked with that myself. I've looked at the piece of how good is the language model, how good is the neural network at doing this, and how does it compare to a mental health professional, for example.
So related to this, I have a question myself. You know, I work a lot on biases, and I will say that, let's say, if I will commit a suicide, at least this will be my way of doing it, I will not tell anyone and just do it.
Exactly.
And you have people that tells all social media. So is there any research on how much bias we have on our knowledge of the problem because we only know the people that talk and not the people that don't talk?
Yeah, no, exactly. And I think there is another like element to this. So people who talk about, you know, those who talk or share that information, that is often encouraged in the context of public health campaigns, right? So like talking helps, not in quotation marks, it actually does, but, you know, it encourages people to reduce the stigma, reduce the taboo. That also means that we often leave behind groups that are not talking. And we can, you know, for a matter of fact, say that, for example, men are at a 4 times higher risk of dying by suicide. When we look at the statistic for suicide, men make up 50% of the population. However, they make up 80% of suicide. And one of the common, you know, causes or issues that we experience around that is that they feel less comfortable talking. Now, those tools in no reality whatsoever would be able to predict anything like it, because there is no slight incidents that could indicate, oh, there might be a risk. Similarly, what is very well known is that people who have died by suicide typically change their behavioral pattern. I think 5 to 7 days, that was the number, before they actually do it, in terms of giving their stuff away, in terms of tidying up their apartment, you know, putting things into order. Again, that's something we'd struggle to capture with those kind of technologies. So yeah, there's a lot of bias into one way of treating the problem.
No, but this is very interesting. So for a follow-up question will be in the data sets that you have mentioned, do you have a gender information? So how many of the tweets, for example, are from female and how many are from male?
Yes.
Can you give me an example?
Yeah, so for social media, no, typically you don't. And there are good reasons for this, that we shouldn't have this. However, that information is available in electronic health records. So we find that the vast majority of suicides recorded, that doesn't mean other suicides don't happen. It just means those that are recorded tend to be overwhelmingly middle-aged men that are Caucasian, that die by suicide. Of course, that doesn't mean other communities or populations or minorities are not included in this, because they are. but the recording is very different. And sometimes the numbers don't really catch up on time for us to look at it. The other thing really is that only very few countries do a recording of the suicide rate, causes, methods, all that kind of stuff after the coroner has determined the death. So as far as I know, there's only the United Kingdom, Denmark, and a third country that I can't think of that does this kind of process to inform their national policy and guidelines on suicide prevention. Recording in the US, for example, is very patchy. A lot of states don't even report on, mental health conditions. And you can see that when you look at public databases in the US, a lot of states can and have just opted out. It's really hard to understand the problem.
So we have another question related to this. It says, when you talk about men and suicide, are you talking about completed suicides? Because men historically are more likely to use more lethal means versus women than when considering suicide. So yeah, the way that they take action is different too.
Yeah, so this is again US specific, and this may vary across different countries. I know for a fact it varies to the UK, but the means of suicide in the US for men specifically tends to be with firearms. That is a huge problem. And in comparison to, other means such as self-poisoning, etc., etc. Whereas in the UK, there are firearms basically as easily accessible for someone. So the means of suicide change from country to country. So when we look at how we can have, comprehensive and holistic approaches to suicide prevention, it is important not just look at the artificial intelligence element, but also the means element and how other factors influence, unfortunately, suicide.
But I guess you were talking about completed.
Yeah, I was completed. Yeah, that was completed suicides.
But I'm sure that was the case.
Yeah.
So another anonymous attendee says, how about mental chatbots like WooBot relying on cognitive behavioral therapy? Do you think they're valuable in reducing suicide rates?
I think it's far too early to say, honestly. They haven't been around for long enough. We know that, unfortunately, some chatbots have led to people dying by suicide through their exchange. So I'd be really curious and interested to see and look behind the doors, so to say, of those companies who provide them, to see what kind of guidelines, guardrails, and different technological interventions they use to make sure that these language models on chatbots don't reproduce those kind of behaviors. I know it is a popular application area of artificial intelligence, but I typically, people like me from academia don't get insight into looking behind the startup doors to see how they configure that kind of technology. So I wish we could.
As an anecdotal case, not related to suicide, but related to use of language models. In Texas, one engineer did a fine-tuning of ChatGPT with a podcast of Esther Perel, a very famous Belgian psychologist that works on New York, that specializes in basically in therapy for marriage or other kinds of relationships. And the reason that this person did that, because one couldn't afford the price of her, and also needed to wait a long time to get an appointment. And at least he said that talking to this chatbot that talked like Esther Perel was very useful to get better from basically a broken relationship that I guess couldn't solve by himself. So this is just a curiosity. And if you're interested, there was an article in Politico end of last year of not only this model, but also another model done in China with Seligman. So basically models that talk like psychologists, and there are no studies on how effective they are. And I would be, like you, very worried that maybe work for many people, but doesn't work for other people.
Yeah.
Greg Howard has, I hope, the last question, because every time we continue, there are more questions appearing. It seems that your position is that the current tools are neither appropriate for predicting suicide risk nor the risk of other acute mental health challenges. What then would be the features of effective tools for prediction? or in the case you think we should entirely avoid risk level prediction, then what is the purpose motivation of your work?
Yeah. So
This
I'm
is a
not.
tough one to finish.
Yeah. The toughest questions come last. Basically, yes, right now with what we have available, specifically for the limited data that we have, right? We have data for very specific populations with very limited factors for very limited groups of researchers who could look into them, right? So yes, as of right now, I don't think we should be doing this kind of risk assessment specifically with suicide. That being said, I do believe that if we can work towards figuring out more causation through social determinants of health factors, aid clinicians through artificial intelligence in an assistive manner to provide that kind of information at the point of treatment, I think it can be incredibly useful. So let's just imagine me, I go to the, I don't know, general practitioner, GP, to the doctor. And it's June now, and I tell them, oh, I'm not doing well. My relationship broke down. I have financial issues, and I fall into the general risk group. And then I don't see my doctor because I tell him I don't sleep, so he gives me something, just a sleeping pill to help me sleep. And I come back a few months later, and I see a different doctor or nurse practitioners, and things gotten worse. I'm having struggled to pay my rent and all this kind of stuff. But because, and understandably so, there's so much pressure, never more pressure than before on the healthcare system. And nurse practitioners, nurses, doctors don't have the time, to review a complete chart of me coming in over and over again over all these months. And so they treat, quite rightly so, that's their job, my physical symptoms. Now, I may now be at higher risk of dying by suicide, and ideally, we'd have some kind of tool or technology that could just extract that information automatically from those free notes, which they do write down. It's not that mental health professionals or doctors or nurses don't care. They do care greatly, but they write it down in a free text. So what if we had a technology that could help us extract that information and bring it to the forefront of the clinician as they treat you, and then look at, okay, maybe we need to change our treatment approach. This is not about her not sleeping. This is not about her having, I don't know, pain, for example. This is about her needing mental health support. So that's how I see this going for now. Maybe in the future, things become different or easier in terms of predictive analytics, but for now, that's where I stand.
So we have a last comment on the Q&A from Matt Miller, and let me echo that comment. Thank you for an excellent talk.
Oh, thank you.
And Greg Howard says that he would love to discuss further offline, so I'm sure you can find Annika's email and contact her to continue this conversation. So thank you again. Thank for the more than 60 people attending this seminar. And we invite you to continue this conversation, because the next seminar will be a special research seminar, because one of the persons that Annika mentioned, Rafael Mestre from Southampton University, is coming to Boston, and he will talk about this topic too. So his title is AI, Ethics, and Citizen Input in Emerging Technologies. Is also related to this work. So please, you are already invited. This will be this Monday, June 17, because June 19th is June 19th, so it's a holiday. And we will have a hybrid conversation with Rafael. If you are in Boston, you can go in person to the Curie Student Center. So you're all invited, and this will be the last talk of the semester, but please come back in September, because we will continue again with our expeditions and also with our distinguished speakers.